Hey everybody, we're going to talk today about cold weather emergencies and cold weather operations as it relates to what we can do in the field for people as emergency responders. So let's get into it. So we talk about what homeostasis is, how that kind of works, and how temperature regulation works in the body. Talk about how we can use our body to maintain homeostasis, but also how our body loses heat, especially in the cold. Talk about some risk factors that predispose individuals, and then talk about cold exposure signs and symptoms. So then we're actually going to talk about hypothermia, what we can do as far as cardiac arrest management with that, and then treatment of localized cold emergencies as we go through. So remember that homeostasis is the act of balance. So that's your body's wanting to balance everything within itself. So when everything is in balance, we're in what's known as aerobic metabolism, and that's the natural tendency for us to maintain a normal environment. So our cells are all working, everything's good, we are good. Our cells are making energy, so the building block of energy is ATP, and we're using probably the Krebs cycle. Not that we have to know that, but the big three things we need for the Krebs cycle are oxygen, a transport mechanism, in this case water, and then glucose. So a circulatory system that's intact to move things around, oxygen and glucose going into our cells to make ATP. As our body starts to shut down because of heat loss, or also because of hyperthermia, so too much heat, we're trying to maintain a normal body temperature, because as things start to go off balance in homeostasis, we stop making energy. So our body tries to do temperature regulation to maintain that 98.6 degrees that we're so used to. So as our body heats up, we try to sweat and shed heat. So we're trying to use moisture in the form of sweat to allow our bodies to cool down. So we can sweat, and then the body kind of takes through convection, like wisps the heat away. In cold, it's the opposite. We try to generate heat because our body is getting colder. We try to shiver and cause energy production so that our bodies heat up. And that's the whole idea between temperature regulation, is that we're either trying to cool down or heat up to maintain 98.6. In severely cold environments, we need to shiver in order to maintain that. But once that shivering stops, that's where our body temperature really starts to rapidly decline. So hypothermia itself is just a temperature below 98.6. So it's generalized cooling that reduces your body temperature below normal. Now, how do you get that? Well, being exposed to a cold environment. That can be being outside for long periods of time. That can be exposed to short periods of time in super, super cold environments. So hypothermia is just generalized cooling that drops your temperature below 98.6. In mild hypothermia, that's where your body temperature is greater than 90 with some signs and symptoms. Severe, your core temperature is less than 90 degrees. So 90 degrees is kind of the barrier between mild and severe. Anything below 90 is severe. Anything above 90 is mild. Now, for us as clinical care providers, we're not going to know what their core temperature is likely unless we take a core temp in the field. We do have the ability, but the odds of us doing that are probably pretty slim. So for us, we're going to be treating more of the symptoms. We don't really need to dive into, is this mild or severe hypothermia, because patients are going to present as they present. We're going to treat those symptoms. Remember that hypothermia doesn't necessarily have to happen in the winter. So you can be in cold water immersion, so like a drowning, for instance, which will force you into hypothermia even in warmer climates. So if the temperature of the water is very, very cold, or kids who are playing in a pool for long periods of time, even when it's like, early spring or late fall, they can go into hypothermia just because they're in cold water immersion for a long time. So heat loss itself, we talk about thermal gradient, and that's the difference in temperature between the environment and the body. So again, your body's 98.6, or at least trying to maintain that, and then it's 30 degrees outside. So the difference between those is the thermal gradient. Now remember that we have different methods of heat loss. So conduction, so that's our body sitting on something. So if we're 98.6 and we're sitting on a cold rock like in this picture, and that rock's 20 degrees, our body heat is going to get zapped to that rock. We're going to try to warm the rock while also the rock is cooling us down. That's the same thing if you sit on a cold bench or when we lay our head on a cool pillow at night. It's our body heat being transferred directly to that object. Convection, remember that's wind, right? So that's wind coming across. Then radiation, that's our body just kind of general, that's infrared rays that we talk about more in a fire. Evaporation being sweat, and then respiration. So you can become super dehydrated just by breathing, because every exhaled breath of carbon dioxide has some water vapor to it. So as we breathe out over time, we actually lose water vapor and can become dehydrated. Remember that when we're talking about wind and just conduction, water will conduct heat away from the body 25 times faster than air. So if someone has fallen into water or if they're wet, one of the first things we got to do is get their clothes off and get them dry, because trying to warm them, a warm or wet environment is just going to absolutely zap their energy. So wind chill is the apparent temperature that's felt on the skin due to the combination of air temperature and wind speed. So again, that's the temperature that's felt on the skin. So it might be 20 degrees outside, but if the wind is really kicking that day, it might have a wind chill factor of 10 degrees. So it might feel like it's 10 or 5. And that's really where we want to be concerned. So we want to, when we're out in cold environments, understand that we're going to be out in these. So we need to take precautions in order to work in those environments. So even if it's 25 degrees outside, but the wind chill is 10, we need to bundle up and prepare as if it's 10 degrees. Wind obviously increases evaporation. So as we sweat, as we get moisture on our skin, that wind takes it away from us and will drop our temperature faster. So we just got to be careful with that. And then we try to conserve our heat. So like we talked about, the natural body mechanisms is the goosebumps, right? So we get these goosebumps, or that tries to impede airflow across the skin, just kind of break it up. And then shivering will increase our muscle tone in order to increase metabolism and drive up energy. As we shiver, we burn energy. The byproduct of that is heat. And then we get vasoconstriction, right? That's our body protecting ourselves. So we start to shunt blood flow away from our fingers and toes and to our central core to keep our major organs perfusing while shutting down things to our skin. And then the big one is also conditioning. So just like in the summer months, we need to condition ourselves for these environments. So as it gets cold, we need to be out in cold environments, getting our bodies acclimated to what that is. The down part about Southwest Ohio and just where we're at is that temperatures can fluctuate wildly just with our climate. So while we can acclimate to cold, it takes multiple acclimations and several weeks of conditioning to get used to that cold environment. So what makes a person more prone to hypothermia? Well, obviously, if you work in a cold environment all the time, that's one big predisposing factor. But also think about like the age. So cold and hot, or any environmental emergency, affects the very young and the very old respectively. So very, very young patients, or our pediatric patients, don't have a whole lot of those compensatory mechanisms in order to protect themselves from the cold. They also don't have compensatory mechanisms to protect themselves from the heat. That's why we bundle up babies in the wintertime, and that's why we might have to shed their clothing in the summertime, just because they cannot thermoregulate yet. In geriatrics, it's kind of the same thing because of other diseases like diabetes, because they might be on blood thinners. Sometimes geriatric people just don't tolerate the cold very well. Add to that dementia, Alzheimer's, and some mental health diseases. Sometimes these people can wander off and not understand that they're actually getting cold. So as they're out in the environment, they don't feel themselves getting cold.
44 Carnegie Way. We're on the scene.
So there are also certain medications, again, blood thinners being the biggest one. And then again, intense exposure or prolonged exposure to the cold, or coexisting weather conditions. For instance, if you're out in the cold and it's raining, you're going to be at a higher risk of developing hypothermia. So mortality is less than 10% for hypothermia alone. Typically, there's due to another factor. So let's say that people want to go out and have a good time and sled ride and this and that. Totally acceptable and an amazing fun thing to do in the wintertime. But as they start drinking alcohol, that also causes vasodilation, which will drop their temperature faster while also numbing the symptoms of hypothermia. So a lot of mortality comes not just from hypothermia, but hypothermia plus drug use, plus alcohol use, plus dementia, plus name the predisposing factor. When accompanied with an underlying illness, mortality rates are 75 to 90%. So this is a very deadly issue, but it's something that we can treat. So some key findings, and we don't have to go through all these necessarily, but just understand that our normal temperature is 98.6. And then at 96, we start shivering. So when we drop just almost 2 degrees, not even quite 2 degrees, we start shivering to raise our temperature back up. Our body senses that something's off. And then at 95 degrees, so just a 3-degree switch between the two, we start getting impaired judgment, maximum shivering, and this is where we start having some body shutdown stuff. It's harder to have fine motor skills. It's harder to understand what's going on. As the temperature continues to drop, we start getting slurred speech, uncoordinated movement. At 89 degrees, our shivering ceases, and then as it keeps dropping from there, we start to go into that severe hypothermic state. Again, the temperature continues to drop. We start getting dysrhythmias. We start to get low pulse rates, altered level of consciousness, and a high risk of VFib at 82 degrees. We can get pulmonary edema at 77 degrees. So as it, again, just keeps on dropping, we start to lose all body function. We start to look clinically dead at 80 degrees. And then finally, we start getting a systole at 64. The lowest adult survival that was accidental was 60 degrees, where they were able to rewarm somebody. And then just past that, the lowest PD survival that's been documented was at 59 degrees. And again, that's pretty unheard of, right? When you get that to that low, the odds of survivability is very, very, very slim. So how long do we have before this stuff sets in? Well, again, it depends on the person. It depends on how they're conditioned to the environment. It depends on what medications they're on, what factors they have. So there's all sorts of things they are. How old are they? So there's acute, subacute, and chronic. An acute would be like someone falls through the ice into frigid water. So they're walking on the ice, they're ice skating, they hit a thin patch of ice, and boom, they're in the water. That's acute onset. Whereas subacute would be like the sled riding, they're out building a snowman, they're doing all sorts of stuff, and hey, they've been out for a few hours now, and they're being caught in that environment. Whereas chronic would be the homeless or elderly to keep their houses cool, homeless people who live in that environment daily. That would be like a chronic exposure. So some early signs of hypothermia, their pulse rate will go rapid, and then as it goes longer, it goes slow and barely palpable. And again, that's because of energy. We're trying to circulate as much blood, oxygen, and glucose to our organs as possible. So we'll get some tachycardia. Blood pressure stays normal and starts to drop. Our breathing speeds up, again, to take in and circulate more oxygen. Our skin initially will look red, but then it will get pale, cyanotic, and stiff and hard as it actually starts to freeze. And then our pupils become super sluggish as we start going. With mild hypothermia, you also get shivering, lack of coordination, lethargy, drowsiness, numbness, and then subtle changes in mental status. They'll be able to converse with you, but that conversation will be slow, sometimes muffled, because they're really struggling to work because their body is so cold. In severe hypothermia, the big one is the lack of shivering. So if a person's shivering, they're in mild hypothermia. But if they're not shivering and they're super cold, they're in severe hypothermia. That's a big clinical sign that we see in the environment. Again, if they have a stiff or rigid posture, they can't bend anything, irrational behavior or unconsciousness, or just that glassy stare, That's severe hypothermia. In both cases, we need to treat them, but one of the things we might see is this slow bradycardic, weird looking ECG rhythm. And what happens is the QRS widens out, your P waves may disappear completely. You might have some baseline artifact, oftentimes it's due to shivering, and then you might get also T wave inversion. But the big thing to see is this strange hump behind the QRS complex. That hump behind the QRS complex is known as a J point or an Osborn wave. So these J waves are not used diagnostically, but if you do see one on an ECG, consider hypothermia. So when you see that J wave and they're cold and you just pulled them out of a cold environment, they are severely hypothermic. They can go into atrial fibrillation pretty easily. They might be very bradycardic, or they actually are very often very bradycardic, but you could see other dysrhythmias as well. The biggest dysrhythmia we want to avoid is VFib, so ventricular fibrillation. And that's what can happen is if we start jostling this patient around in the environment, we could put them into VFib. Now, this is a very old study. It is still a thing though. So what happens is we're packaging the patient to extricate them out of the cold environment, and we're tripping over a lot of logs or trees, and we're just shaking that patient around. Because they're so cold and their heart is so sick, we can actually put them into VFib. So anytime we're moving a patient, it has to be very coordinated, very smooth, very slow. And we might think that's counterintuitive because we need to get them out of the cold environment. We need to get them warm. And yes, we do. However, we can't get them out of the environment and warm quickly at the risk of VFib and other dysrhythmias. So plan your movements, go slow, and just make sure you bundle them up. So as we're extricating them from the environment, a lot of blankets, get their wet clothes off of them, start active rewarming in the field as we start moving them to the medic unit. Some signs for our cardiovascular stuff: sinus brady will start to appear less than 95 degrees. So as we start getting closer to that 90-degree mark, the bradycardia speeds up. AFib at 85, and then our blood pressure really starts falling. So does our pulse rate around 84 degrees. Anyone less than 82 is a real high risk of VFib, and then complete cardiovascular collapse at 75. But again, these are just general ballpark numbers, based on some studies. Anything less than 85 degrees, 80 to 85 degrees, that patient might look unconscious or deceased. So that's why we're going to treat the symptoms versus the number. So how do we treat them? Well, first things first, get them out of the environment. So we have to get them out of the cold. So whatever we have to do to get a medic unit to them, let's make that happen. So that might include, hey, putting a medic in some really awkward positions just to get the heat of the ambulance to them. If they are a lost person search, or we know they're going to be back into a difficult access area, then one of the things we can do with that medic unit is crank the heat on in the back while waiting for the patient to come to us. Think about Stokes baskets, think about rope systems, think about a lot of packaging in order to get that patient to the medic unit safely, securely, and to get them warm. Again, get any wet clothing they have off of them, just because that water will just zap the heat right out of their body. We want to protect against further heat loss. So, for instance, if we're going to cut their clothing off in the field, which is something we might have to do, make sure we have enough blankets and heat packs and all those things before we start cutting their clothing off. The last thing you want to do is cut their clothes off, be like, oh, we don't have enough blankets. Now we're actually compounding the problem. So it's a very common sense thing, but make sure before we do any actions like that, that we have enough resources on hand to manage them. Transport them horizontal, right? We don't really need to sit them up again because they have an altered mental status anyway. There's a really good chance that our airway is going to crash. There's a really good chance of a lethal dysrhythmia. So we want to maintain them horizontal, avoid the rough handling, and then humidified oxygen. So you can put saline into a nebulizer and then provide that because they need the water because they're also dehydrated. And then you can also tape heat packs around the oxygen tubing. So as that oxygen passes through the tubing, hopefully the heat pack warms it up and allows you to have warm, humidified oxygen. It's a down and dirty field way of doing it, but it can have some success. So I would highly recommend trying it. We try and monitor core temperature. Again, not always possible with the equipment we have, but that's a nice thing to let the hospital know. Again, we're going to know they're hypothermic, so we're going to treat them accordingly. And then the other thing is to monitor the cardiac rhythm while also administering warm IV fluids. So again, the medic units are equipped with heaters. If that doesn't work, tape heat packs to the saline bags. Warm the saline, and as it passes into the body, you'll get warming sensation there as well. So warm fluids, warm oxygen, warm environments, really everything opposite that they've been in. Things we don't want to do. Allow them to walk around or exert themselves because again, they're already tired. So even if they have that irrational behavior, they're not making any sense, we want to control that patient and bring them into the medic unit. Don't allow them to eat or drink, especially cigarettes, alcohol, things like that. Alcohol is going to vasodilate them, make them actually more cold. So, don't, not that we would ever give someone a shot of whiskey, but we don't want to do anything that's going to affect that. So don't let them eat or drink. Again, the risk of airway collapse is pretty high. We don't want to massage the patient's extremities. We don't want to handle them roughly. And then we don't want to rewarm too quickly, right? So if we're dealing with like things like frostbite, where they actually have frozen appendages, if we rewarm too quickly, we could actually damage that tissue even further. So don't massage extremities, don't cause rupture to blood vessels. So just bring them up gradual and make sure that we're treating them appropriately. So how do we rewarm? Well, passive is for those who are unresponsive, who have an altered level of consciousness. We allow the body to rewarm itself. So we turn the heat on in the squad, we cover them with a lot of blankets, and then their body temperature starts coming up because we're putting heat on the body. So that's passive rewarming. The body starts just to naturally warm up themselves. This takes a long time. So, but anytime we're treating hypothermia, we will be doing passive rewarming. Occasionally, we might have to do active rewarming. This would be more of a field thing for if a patient was trapped out in an environment, we couldn't get access to them. This is more of like a wilderness type thing, but where we would do body to body heat, where we actually take our bodies, put them on theirs, and that way we pass heat to them. You could do warm water immersion, so warm bath water. This would be for like a limited extremity. But then heat packs, hot water bottles, forced hot air, then warm IV fluids. The only real rewarming that we probably will do in the field is the warm IV fluids and then hot packs. So the hot packs need to go, just think of where your core is, into the armpits, behind the knees, into the groin, behind the neck. So all places we can put heat packs just to help get the body warmed better, while also doing heat in the ambulance and then blankets. So American Heart Association actually has changed their CPR guidelines. Before, it was really withheld to hold off on ACLS treatments. The idea being that, hey, if we're doing CPR and ACLS, what's the odds it's actually going to work? The theory being that, hey, this patient isn't clinically deceased, so why are we pumping them full of a bunch of cardiac arrest drugs? The problem there is we don't know if they're clinically deceased. They may be, they present like they are, we're doing CPR as if they are. So now the American Heart Association has kind of reversed its stance and said, hey, treat them as a normal code. So if we think they're in VFib, treat them in VFib. They used to limit the amount of shocks. That is no longer a thing. So currently we're going to treat this just as a normal cardiac arrest and treat them as necessary with your anti-arrhythmic medications. Again, try to obtain a rectal body temp in the field, but don't delay transport. If we can't get it, we can't get it. Prevent further heat loss, treat gently, transport promptly, and then warm IV fluids. As far as treating gently, obviously CPR is not the most gentle thing, but again, getting the Lucas device on, getting that handled, and then just being careful with grabbing an extremity to start an IV, we're going to be a little more gentle and a little more cautious if we're ever treating someone with severe hypothermia. Patient's not dead till they're warm and dead, so we are not going to field terminate hypothermic patients. So there's a lot of stuff that the hospital can do. We want to make sure the hospital is aware and understands that we're bringing in a hypothermic patient. But between active rewarming, ECMO, and a lot of capabilities in the ER and ICU, we transport hypothermic patients. Now, there's a caveat to that. If they are physically frozen solid, that would be incompatible with life, not the same thing we're talking about. But if we have someone who's wandered off into a field, wandered off into the woods, we find them several hours later, and they are unconscious, hypothermic, we are going to move that patient, gently treat them, and then transport. So what about some other common cold injuries? Well, it obviously affects the things that are mostly exposed to the cold. So if you don't wear gloves, if you don't have the right footwear on, it's going to affect your hands, your fingers, your toes, your feet. Also think about your ears, your nose, your face, anything that's exposed to the cold for a long period of time. Frost nip is where you just get reddened skin and then blanches, gets numbness. The skin's still soft. As your warms up, your skin starts to tingle. We've all experienced frost nip. So the prognosis of frost nip is very good. There's no major damage that occurs here. It's just that it's just uncomfortable as your body starts warming back up. There might be clear lines of demarcation. You might get gray yellow patches or blisters, but frost nip itself is not a major concern. However, frost nip left untreated starts to develop some really bad stuff. So we want to get them out of the cold, warm them up. This is where they can rub their hands. They can put their hands in their pockets, just kind of control them. If we do have to treat this, we might splint it and then just keep their fingers and stuff kind of separate a little bit. As you can see there, they put gauze in between each one, which is a nice way to do stuff, but we don't want to allow any further damage to the cold. With deep local injuries like frostbite, this is where frost nip's not treated. It looks a lot like a burn. So you'll get white, waxy skin, then gray-blue skin. That's because of the cyanosis and necrosis that starts happening there. You'll get swelling and blistering. It's a frozen feel on the surface. It'll feel solid. And then the skin under has some normal bounce. So the extremity itself feels solid, and it might have a little bit of a bounce to it because it hasn't frozen all the way through. You might get large blisters. You get a lack of sensation, but that edema, that swelling, can last up to 5 to 7 days. If it's completely through the dermal layer, subcutaneous tissue, and down into everything else, basically your tissue dies. So when that occurs, it can lead to eventual what they call mummification. Basically, your skin's completely broken. This leads to amputations when left untreated. So with this, it's just more of a be careful, don't break an extremity off. Their skin itself is frozen. Their blood vessels underneath are frozen. So this is one where we splint it, protect it from further injury, but there's a good chance they're not going to keep their fingers. In this case, again, removing from the cold environment, high concentration oxygen to the other tissues, again, warmed oxygen, start the IV, keep them hydrated, and then we may, if we're delayed, have to do rewarming, but that's one that goes through medical control because if we rewarm the extremity and then it cools off again because we're delayed, that's going to cause more damage. One way that we can do active rewarming in the field, if medical control were to allow that, is we just get a bucket or a tub, heat the water to 100, 105 degrees, so just use hot water, and then fully immerse the body part. Don't put any pressure on it. So we can just keep adding warm water to maintain the temperature. We dry it, and we keep it slightly elevated during transport. Again, this is more of a field thing. If we didn't have rapid transport to a hospital, the odds of us doing active rewarming is pretty slim. Things we don't want to do in frostbite: rub with snow, dry massage it, use radiant heat, rupture the blisters, Again, those blisters are there to protect the skin even further. If we puncture the blisters, we have an open route of infection. There's no ointments you can apply to fix it. Don't use any tight bandages. Don't allow it to refreeze. And again, just like previously, no smoking, alcohol, things like that. That's going to cause further vasodilation, further damage to the extremity. Passive is always permitted. So again, the way we do passive rewarming is turn the heat on the squad, allow heat packs to kind of get onto the body, just let your body rewarm naturally. But anytime we want to consider active rewarming, call medical direction. So how can we protect ourselves in that environment? Well, limit our exposure as much as possible. Now, we don't get to pick when we get toned out. We don't get to pick what environments we work in, but we can be proactive and understand what we have. So number one is have appropriate PPE. If we know it's going to be very cold outside, consider base layers, consider thermals, consider anything that we can do to maintain body heat. Maintain our exercise and get a good diet in. So make sure we're well hydrated, make sure we're ready to go, make sure that we're acclimated to the environment. So we've spent some time outside in the cold just to condition our bodies for it. Make sure that our medic units are stocked with towel sheets and blankets and extra ones at that in case we have to really wrap somebody up. Make sure we have clean, spare, dry clothes in the station or preferably on the unit. Me personally, I always carried a cold weather bag that contained thermals, a towel, an extra knit hat, extra gloves, an extra sweatshirt, a face hoodie thing. And that was all just there for me. I also had a spare Nomex and spare fire gloves. So just for if I ever got wet out in the field, I had a clean, dry set of stuff to go back into. For the guys that have been around a while that run cold weather bags, take a look and see what gear they carry and develop your own. When it's super cold outside, you're going to want a cold weather bag on the truck with you to change out your equipment, especially Nomex hoods, especially gloves, socks, things like that. So at the end of the day, hypothermia is a very big deal. There is a high risk of morbidity and mortality with it. The best way that we can to treat them is to get them out of that environment and start warming them up. Again, warm IV fluids, hot packs on the armpits, groin, axilla, and around the back of the neck. Don't forget to put and consider hot packs on IV tubing, hot packs on IV bags, and hot packs on oxygen tubing just to help to warm that process up. With good treatment, we can affect good outcomes, but remember, they're not dead till they're warm and dead, and follow your ACLS protocols. Thanks, guys, for watching.